All right, welcome everyone. We're going to go ahead and get started because we have over 60 people on web, online as well too, which is great. And so hopefully those of you online can hear, and then we'll be recording this as well for if anyone wants to check in later. So yeah, I'd like to welcome everyone. My name's Parmi Sachdev. I'm the Associate Director of the Emory Global Health Institute. And on behalf of the Global Health Institute, welcome to our Global Health Forum. We started these last year, and we host these forums quarterly to bring together people from across Emory University, across different disciplines, and from the community to discuss timely topics in global health. And I can't think of a more timely topic than what we're going to be talking about today with the coronavirus outbreak. And I'd like to thank our EGHI staff for putting this together, and in particular, Britton Tuck, who did all the legwork and getting this together, and for our panelists and moderator for being here as well. So we believe in science, we believe in data here, and so we want to collect some data. So I know the students probably already have the Poll Everywhere app. For those of us who don't, you can just text EGHI to 2233 and please fill out these couple of demographic questions. This will help our panelists also know who's in the room. I'm going to log in as well. The faculty are still trying to find their phones. All right, we'll do a couple more and then we'll start going. Okay, great. And so your next question is, if you're here at Emory, what's your primary school affiliation?
Can we cheer for one?
Yeah, absolutely. You can cheer. All right, great. So mainly the med school and public health, and we have some students from our folks from the college too. Oh, business school too. Woohoo. All right. How worried are you about COVID-19? Oh. Great. Okay, so we're here to talk about the novel coronavirus, or COVID-19, and it's you can't escape the headlines in terms of fears of there being a global pandemic, a community spread in the United States, forced quarantines, the tanking stock market. But there's also another concern in terms of a war on truth. And one of our goals here is to equip you all with some facts, and so that you leave the session more informed about what's really happening and how you can educate your peers and your students and their colleagues about the coronavirus outbreak. So some numbers here in terms of number of cases, deaths, and cases in the US, and the number of CDC staff involved in the response, now over 1,300. They just put out an MMWR a couple of days ago. And then I did a PubMed search this morning, 119 papers, according to PubMed, on COVID-19 so far. And as compared to the flu deaths so far in this flu season globally, is estimated to be about 41,000. So yes, after the session, we hope you all will have survived COVID-19. And that really our theme for the session is about preparedness and how to prepare ourselves both here domestically in the US as well as globally. And so the way we're going to do this is we're going to have four invited panelists who are really experts on some of these issues related to coronavirus, who are going to give a brief 35-minute overviews of their assigned topics, and then we'll have a moderated Q&A. So what I'll do is I'll introduce the speakers all at once now, and then we'll have them come one by one up to the podium and give their remarks, and then we'll have them follow up with the panel discussion. So our first panelist is Dr. Henry Wu, who's an infectious disease physician at here in the School of Medicine at Emory, and he also serves as the director of the Emory Travel Well Center. He also was previously a medical epidemiologist at the CDC, In addition to travel medicine, his interests include infectious disease epidemiology, central nervous system infections, and evaluation of patients with serious emerging infections. So Dr. Wu is going to give us an overview of the epidemiology of coronavirus, as well as some of the clinical features. Our next speaker is going to be Dr. Mary Beth Sexton, who also specializes in infectious diseases here at Emory. And she's the medical director of antimicrobial stewardship for Emory University Hospital and the epidemiologist for the Emory Clinic. She's also a staff physician in the Serious Communicable Diseases Unit at Emory University Hospital and co-chairs Emory Healthcare Committee dedicated to coronavirus preparedness. So she's going to talk to us about the health system preparedness. And our third panelist is Paul Meyer, who's Assistant General Manager of Operations and Transportation at Hartsfield-Jackson Atlanta Airport. He oversees operations to ensure a safe, efficient environment for more than 107 million passengers and more than 870,000 flight operations annually. Mr. Meyer retired from the U.S. Air Force Reserve at the rank of colonel in 2015, and he's going to talk to us about preparedness efforts at the airport. And then last but not least, we have Dr. Jim Lavery, who's the Conrad and Hilton Chair in Global Health Ethics and a professor in the Hubert Department of Global Health at the Rollins School of Public Health. Dr. Lavery will be addressing some of the ethical issues related to quarantine policies and other commentary on the other panelists' presentations. And then to moderate this fantastic panel, we're really glad to have Dr. Hansa Bhargava, who's the Senior Medical Director at WebMD and Medscape. She's a fellow pediatrician and serves on the American Academy of Pediatrics Committee on Communications and Media. So with that, I will turn it over to Dr. Wu to come start the panel. Thank you.
Okay. Thank you. Everyone hear me all right? Thank you, Parmi, for the invitation. Very happy to be here and talk about this timely topic. As he's mentioned, I'm going to cover what's basically known right now clinically and epidemiologically about COVID-19. Again, this is all very preliminary. It's changing very quickly, so I'll try to just address what we know and what's not clear at the moment. This is just a reminder to tell you about what my job is like on a daily basis, even when there aren't any pandemics going on. People are traveling everywhere. We're very connected. You can get around the world much faster than the incubation period of almost any infection. So if you're wondering why we're talking more and more about outbreaks, this is part of the reason here. So you heard the numbers. This is a screenshot from Johns Hopkins dashboard if you're interested in following the numbers on a daily basis. Personally, I don't, but once in a while I take a look at it. But as you know, it started in China, Hubei province, centered in Wuhan. It since has obviously spread to other countries, some with kind of more concerning recent increases, including South Korea, Italy, Iran, and Japan. So certainly this has certainly made the news. What's going on in the U.S.? Now this slide's already out of date, so you've probably heard in the news this morning, a case in California. No, so far, no clear contacts of travel. Obviously, that's potentially very concerning. I'm sure our colleagues at CDC in California are investigating that closely, so stay tuned for that. But before that, we had a handful of cases. You know, the confirmed cases, what that means is cases confirmed here in the US. Now, the majority are travel related, meaning they returned from China, primarily Hubei, and diagnosed here. 2 more were diagnosed following person-to-person spread from those individuals. Next, we have repatriated cases. These are folks that were diagnosed overseas and returned back to the US for care and quarantine. 3 from Wuhan, 42 from the Diamond Princess cruise you've all heard about. Finally, I want to emphasize one thing. This is the number of total tested in the US. It's 445. Obviously, our testing capacity is still fairly limited. And considering the volume of travelers every day, which I'm sure we'll hear about, you know, it is something that I'm sure CDC is working on to increase capacity. So far, testing has been very targeted towards high-risk individuals. Epidemiologic considerations, I think you folks all know this is related to SARS and MERS. The sequence is most closely related to bat coronaviruses. So far, we do think it's primarily transmitted person to person through respiratory droplets. The role of contaminated surfaces is unclear, but but we do, again, think it's primarily through respiratory droplet spread. We do think it's primarily spread from symptomatic infections. However, there are some very notable case reports of spread from folks who appear to be asymptomatic. So that certainly is of concern. Some data from China, like SARS and MERS, this does have a heavy burden on healthcare workers, and 4% of cases in China. Also interesting out of China is that very few cases have been reported in children. And now that there are many reasons why that could be. Maybe they're not getting sick, maybe they're just not showing it, or maybe they're not coming to clinic because it's mild. But again, that number of cases under 19 in China is quite interesting. Now, finally, the reproduction rate. This is the epidemiologic statistic in terms of average number of people infected case infects. It's all over the board right now. I think we'd safe to say it's greater than 1, which means these epidemics can progress easily. We knew that without doing those calculations. Incubation periods primarily around 5 days, range 2 to 14, we think. Again, it looks primarily like the flu or common colds. This is what makes it challenging to identify. Fevers, fatigue, cough, maybe sore throat, diarrhea sometimes. Shortness of breath is primarily, I think, we're seeing in hospitalized patients. And again, asymptomatic cases are reported. It appears, at least in the Chinese experience, about 20% of cases are hospitalized and about 5% are critically ill. Complications, respiratory distress, pneumonia. This is x-rays from a case in Vietnam, and it's quite obvious. You can see the progression of the x-ray there. Case fatality rate, again, the basic statistic. If you get this infection, how likely is somebody going to die? And the numbers are all over the board. And the reality is these are all crude numbers, very preliminary. So I don't think we can take any hard conclusions yet. But just for example, if you just take numbers from Johns Hopkins, number of deaths, number of cases, you get a number like 3.4%. China's reported something like 2.3%. If you look at hospitalized cases in China, obviously it's much higher, as well as the elderly. Here's the interesting statistic that China put out this week. Hubei case fatality rate's 2.9%. Outside Hubei province, it's 0.4%. Again, it asks for a pause of why that might be the case. Healthcare workers, 0.3% in China. And I did my own calculations on the Diamond Princess. So far, 4 deaths reported, 700 cases, about 0.6%. So what's going on here? I'm not sure, but I'll let you kind of take a peek in my brain of how I'm starting to look at this. Obviously, sicker patients are more likely to die. I think that's common sense. I think it's also clear in a lot of these numbers, we have overestimation because they are just finding the sick cases, or those are the ones that are presenting. So I think that's obviously a major factor. Now that kid said there could be underestimation in recent case series. If nobody, they're still in the hospital, there may be deaths pending in active cases. Certainly, populations that are older may have higher case fatality rates. I've never been on a cruise. I don't want to stereotype cruise ship passengers, but I get the feeling they may be on the older side. On the other hand, I do think, again, healthcare workers are potentially younger, healthier, and maybe that's why some of these numbers, I'm trying to put some sense to this, but the reality is we don't know. That's why you're hearing a range of numbers. So with that, I'd just like to mention real quick here, diagnosis, primarily molecular. Treatments are mainly supportive. There's some experimental protocols. Hand hygiene, all the personal prevention things that you all know, those healthcare workers, we do personal protective equipment. Community containment measures are potentially important. This is what's been in the news lately about preparations in the US. Certainly China's done a lot of this, vaccines and development. Finally, as I want to emphasize, the challenges are this resembles many common illnesses, and the possibility that asymptomatic or mildly ill patients can spread the disease is potentially a challenge. Thank you.
Okay, thank you. So I'm going to talk a little bit about what we do as a healthcare system to prepare when we have a novel infection like this that starts to increase in case numbers. And at Emory, we've a unique situation because we have a serious communicable diseases unit that was internationally known in 2014 for taking care of Ebola patients. And that got a lot of media attention. And more recently, that bottom picture is the Fox News show The Resident, where they had a patient with a possible viral hemorrhagic fever, and the tagline was, "We're going to send him to Emory. Emory will handle it." And so there's a lot of good things about that kind of reputation. It means you've got a strong talent base, a lot of knowledge, a lot of capability, but that also carries a lot of responsibility with it, that you continue to be a leader in that kind of field. And when we say Emory, what we mean today is a huge group of facilities. We have multiple hospitals. We have more than 200 outpatient clinics that see up to 15,000 patients a day in outpatient visits. We also have the Emory Healthcare Network that has our name on it. It's a series of physician practices and urgent care facilities. So we need to make sure that every one of those facilities that carries the Emory name is prepared to carry on that legacy of being prepared to handle these kinds of patients. Emory also comes with some unique challenges. There are very few hospitals that are on an undergraduate campus. And what this means is that in a true pandemic, Emory University's hospital's emergency department could be overrun by undergraduates if you exceed the capacity of student health. We also have Hartsfield-Jackson International Airport that you're going to hear more about, but you've got the busiest airport in the world down the road. And what we're trying to avoid are a couple of things. One is the individual scenario where a patient presents somewhere in your healthcare system and you miss them. And this is what happened to Texas Presbyterian in 2014 with Ebola, but this isn't a knock on them. This could have happened anywhere. But they had somebody come into their emergency room. They didn't recognize the travel history and the symptoms, and so it delayed the diagnosis. That patient did ultimately die. That might have happened anyway, but it's possible that an earlier diagnosis would have helped. They had 2 staff members infected. Their bottom line took a 25% hit in the subsequent year, and it did contribute to panic in the United States about our ability to contain Ebola. And then what you're seeing now in China with coronavirus cases, with more than 80,000 of these identified, is that they've got significant capacity issues. We saw pictures in the media of people lining up around the block to get evaluated by a hospital or a healthcare clinic, running out of medical equipment and personal protective equipment like masks. And that contributes to panic. So when we talk about preparedness, we're talking about both, can we identify and manage the individual patient, and can we handle a surge? And so I'll talk very quickly about that first component. And what we do within Emory Healthcare is we've established a really robust screening process where we ask all patients at all points of entry, do you have a new fever or a new cough? And everybody who answers yes is supposed to get a mask. That protects against things like influenza and would help us significantly with a novel respiratory virus outbreak like COVID-19. And then we ask about travel. And we have added China to that screen, and discussions are ongoing about whether anything else needs to be added. And what we do is if we flag that case through screening, we give people a mask. If they have symptoms plus travel, we isolate them. And our infection prevention department screens those cases further to determine whether they really meet criteria. And we notify an infectious disease physician to evaluate the case if they do. What to know about that is that those calls to IP in the last month, we've had almost 40 now, and that's just asking about China. Now, clearly, none of these people had coronavirus. Most of these people didn't even have symptoms, but you get a lot of worried well and a lot of panic in these situations. And so if you think what happens to the volume if suddenly you're asking about South Korea and Italy and Japan, or even just do you have a fever or a cough if this goes worldwide, we don't have that kind of capacity necessarily in our infection prevention department. They're supposed to be doing other things. You always have to think about unintended consequences. They're supposed to be helping people in the hospital not get hospital-associated infections. So you need to think about other ways to manage this. And we know that probably new travel advisories are coming. We may see new criteria from CDC for testing in the next week. And we have, as Dr. Wu alluded to, some issues with our ability to scale up testing capacity, because right now we're sending everything to CDC. So on that topic of surge planning, as we hope doesn't happen but may, what hospitals are thinking about is, first of all, those greater than 80% of patients who are mildly ill. You don't want those people taking up hospital beds in a pandemic. You've got all the people who normally need to be in a hospital, the people who are having heart attacks and strokes. And then you've got that 15% who really do need to be in the hospital and the 5% who are critically ill. And that's where you want to put your attention. So this is where we really partner with public health and try to figure out, is there somewhere else we can put people? Can they stay at home and isolate themselves there? Is there another facility they could go to if they have young children at home or they don't live alone? And these are difficult questions we have to wrestle with. And then on an inpatient side, can you cohort people? Does your staff have training in using the appropriate personal protective equipment? Do you have room controls? And what are you going to do about critically ill people? And that's where we've thought about using our biocontainment unit, just because the amount of time people need to spend with the patient and in that personal protective equipment. People who have not worn an N95 respirator, they are not comfortable. So wearing one for hours on end is a problem. So we might consider those, what looks like the spacesuits that you saw with Ebola, not because they're necessary for the pathogen, but because they help people's comfort. And then if you exceed that capacity, that's when you need to figure some other things out. So at Emory Healthcare, we're in the process in committees dedicated to each of these topics of determining our planning procedures. What's each hospital going to do? Are you going to cohort patients at one and then have the others pick up the slack of other types of patients? Or are you going to put patients everywhere? How do you control your supply chain? A lot of our PPE is made in China, including a lot of our masks. From a critical care perspective, how do you staff? How do you use your resources best? Usually our ICUs have 1 or 2 airborne isolation rooms. So do you take over an entire unit or do you scatter patients? From an occupational health standpoint, how do you monitor your healthcare workers to make sure they don't become symptomatic? And from a human resources perspective, a lot of the time with these novel pathogens, we operate on a volunteer basis. Like our serious communicable diseases unit at Emory, all of those staff volunteered to do that. If this becomes a pandemic, you may not have that option. So then it's a question of, if you require staff to do this, what are you prepared to do if they refuse? And who should be excluded? How do you communicate to your staff and to the community so nobody panics? And then how do you partner with people like your EMS transport services, the airport quarantine center that would send us patients potentially, with the university, with graduate medical education? This is not necessarily something we want medical students or residents having to take care of as first line. And so those are all the kinds of considerations that we're making.
Good afternoon, everyone, and thank you very much for the invitation. This is a very topical subject that we're working on, and the airport. So what's going on at the airport? Today we'll see 300,000 people come through the airport. 70% of them will be just transferring. They're not getting off. They're not leaving the airport. They're just going from one flight to another. 30% of them are either arriving to the airport or departing the airport as local. 2,600 airplanes will come and go. So we talk about how do you prevent the spread of things. That's one of the concerns with the air transportation system is how do we prevent the spread? And we're not to that point yet, but what I want to focus on today is what are we doing at our 2 international terminals in terms of screening? You heard that we have a CDC quarantine facility out there. It's not really a quarantine facility, but we do have CDC out there. We call it the quarantine facility, but if the CDC representatives that are at the airport recognize that someone needs to go see a hospital or be quarantined, they don't quarantine at the airport. A lot of the media think we have these big rooms at the airport that we're going to house people in for 14 days, and that's not the case. So what do we do at the airport in terms of coordination? We have a lot of federal agencies at the airport. It's we call it alphabet soup down there because there's TSA, FAA, CBP, CDC, you name it, they're there. We have conference calls nearly every day. We have one today, which is nationwide, with the 7 other airports that are funneling passengers. If you're coming from certain areas from Asia, you can only come to the United States into one of 7 different airports. We have the conference calls, we have a lot of stakeholders, and I'll go over that in a minute. And of course, we have messaging to our employees and the passengers. I was interested to see that you have the same sort of chart that we're using at the airport. This is pretty good. We don't take this, we're not quite sure of the accuracy of the information, so we don't take action off it, but it's interesting to see where across the world that the red dots are starting to show up, because then we start looking at, okay, what flights may be affected. We've already seen our flight from Shanghai be canceled. Delta doesn't fly that anymore. Not until hopefully in the next few months they can start that back up if this dies down. We've also seen our flights from Incheon, South Korea be reduced. And we're just worried, and hopefully it won't happen, but if we start to see the red dots show up in other places, that maybe flights from those other areas may be reduced. So we hope not, but we'll know about it well before it happens from the carriers. I talked about the different stakeholders at the airport. There's a lot of people to coordinate with, from facility operators to the custodial staff, emergency management, the news and social media. I mean, the social media alone, we subscribe to the service that tells us all the social media, all the tweets that go out that involve the airport. And it's amazing how many people tweet, "I just saw someone in a mask." Uh-oh. Like, oh, and that's how it spreads. That's how I won't say panic, but that's how the concern spreads. But there's a lot of stakeholders at the airport that are involved. Notification, if we have someone coming in on a flight that appears to be ill, we'll get the call from the FAA Air Traffic Control. Normally the pilot calls in and says they'd like the paramedics to meet the aircraft. And remember, we're just talking international right now. We're not talking the domestic cases right now, unless it's to the point where the CDC feels they want to see them. But right now, we're focusing on international arrivals. We notify the first responders, our airport paramedics, meet the aircraft along with representatives from the CDC that are stationed at the airport. Customs and Border Protection. They are looking at everyone that comes in. They're looking at everyone's itinerary. So if you flew in from, we'll just say Shanghai to Paris to Atlanta, they know that routing and they're going to interview you before you go any further. And if they have any issues, CDC is right there. So they are tracking the people's itineraries as they come into the country and try and evaluate them, look at them, educate them. So that goes on all the time throughout our international concourses. Facility treatment, if we do have an issue at the airport, we do have a biohazard company that's here in Atlanta, then we partner with them. We used them when we had the Ebola issues, and I think it was MERS and SARS, and even anthrax way back when. Every time there was white powder somewhere, it was suddenly anthrax. So obviously none of it was true, but we had a biohazard company on staff just in case. And of course, the employees, we try and keep them updated. We don't want them to be worried and them not show up to work, because then we have another problem. So we follow the guidance from CDC as to what PPE should be used, and we make sure that all the different companies, remember there's concessionaires, food, beverage, retail, baggage handlers, custodians, security, so many different companies out there at the airport that we try and point them to one spot and say, if you want to use PPE, this is what they're recommending. So that is a very quick summary of what's going on at the airport, and we'll answer some questions a little bit later.
Thank you very much. See if I can figure this out. To the side. So, I mean, what you've heard is just an incredible set of complex tasks that have to be executed. And what I want to do is kind of try to come up to the 30,000-foot level a bit and just ask some broader questions about how to make sense of all this. So, during Ebola, the West African Ebola outbreak, I was in Toronto and I wrote an op-ed in a Canadian national newspaper, and then I got invited onto TV to do this like live TV thing. So I was talking to the producer about what I was going to say, and we had it all set up. And then I got on live TV with the anchor, and he said, you know, in a situation like this, we don't even know what questions to ask. What are the key questions we should be asking? Of course, that had nothing to do with what I'd prepped with the producer, and so I was kind of stuck. But I thought, well, it's actually a nice way to think about this. What are the key questions about the sort of ethics that we might have to try to get our minds around? So the first one, I think, is what are the upstream causes of all of this? You know, and why does that matter ethically? And so there's a really nice piece in the New York Times today, in fact, by Peter Daszak, called "Welcome to the Age of Pandemics." And you know, he talks about this disease X that had been forecast for a long time, and it's exactly COVID-19. These are not unexpected ideas. We know the causes, we know they're zoonotic, we know a lot about the way that human interface is going on with animals and how these things cross into different species. But we really, I think, prefer to manage crises than we do to focus on prevention. I think that's a really important place to start with this, because as the great Larry Brilliant said, outbreaks are inevitable, epidemics are optional. And I think that's really true here. So let's not lose that like broader framing. The second question is, how do international relations and international relationships affect everything that's just been described here? You know, there's been a lot of discussion about China's willingness to allow CDC, for example, into China to work alongside their counterparts in the China CDC. And this reflects a state of the larger power struggle between the countries, not simply whether or not people are being accommodating for their public health associates. And this is a really fragile state of international relations, I think, to do the complex things that have been laid out so nicely for you here. One way in particular, I think, that this presents itself is around data sharing. So there's been a lot of talk about data sharing and some reluctance, I think, to share data so that we kind of understand. But at the same time, if you go to the web, you can get the entire genome of this virus already. It's up there. There's incredible data sharing in some spaces, but not in every space. So we have to kind of get a better understanding about why that's the case. I think the obstacles are largely political. Go back to the example in 2007 with the H1N1 influenza epidemic with Indonesia. It said, oh, what, you guys want our samples? But you know what? We're not going to give them to you, because every time we give you our samples, we don't get easy, ready access to affordable vaccines. We just give you the samples. So this broader international relations piece, I think, is also really critical to how we think about the ethics. The next question is, who's in charge? So if you look internationally, the international health regulations give WHO authority to declare public health emergencies of international concern and to therefore make travel restrictions and that kinds of things. But they're kind of silent on exactly how quarantine or isolation or containment ought to be done. Those are left largely to the states, to national states. Then you have, say, the International Covenant on Civil and Political Rights. And there's a set of principles called the Syracuse Principles that provide what's called derogations. When is it okay to not follow those or to violate those principles in the International Covenant? And in order to do so, in other words, to enact quarantine, to deprive people of civil liberties, it has to be done in accordance with domestic law. It has to have a legitimate objective. There has to be strict necessity to achieve that objective. There has to be no less intrusive ways to achieve those objectives, and they can't be imposed arbitrarily. And I'll leave it to you guys to think about whether anyone really cares about that anymore. I mean, it's sort of, when we're in a real crisis, these things really just slip aside very, very readily. Domestically, we have way more than 2,000 health authorities in the United States and the territories and tribal authorities. The federal government has quite limited general authority, like ports of entry and things like that. But we have an 1890 Epidemic Disease Act that gives the authority to the federal government to override some of those local or decisions. But it hasn't been debated even or tested in modern times. And there's a lovely piece by Professor Polly Price from the law school here at Emory in the Atlantic on February 16th, laying out some of those issues. So I was going to do a whole thing about why the truth matters so much, but the 2-minute warning has already been signaled. But I think that this general notion of how institutions have been so badly damaged and their authority so badly damaged by just rampant lying. And I think we can call it whatever we want. We can dress it up however we want. But this assault on institutions and their authority through just this incredible carelessness about lying, I think, damages everything in the background for these problems. So, how can quarantine be applied ethically? And I'm just going to give you the 4 kind of main considerations, and I won't go into any detail about them. One is that, you know, they're all founded on this notion of the harm principle, that it's not about protecting you, it's about protecting harm to others. We struggle with this in the society that probably has the greatest attention to individual liberties. That's a bit of a stretch. The least restrictive means you've already heard about in the Syracuse Principles. There's also this notion of reciprocity, and we heard some signals about this already in the earlier talks, that if you're going to deprive someone of their civil liberties, then you have some obligations to be reciprocal to them. What are they losing? What costs do they have? And how can we help them sustain those costs? And then finally, this notion of these things ought to be done in transparent ways. And there's been a lot of coverage in the media about what exactly that means. And I think it really requires a lot of vigilance from our part as sort of, I was going to say citizens, but I'm Canadian here anyway, there you go. So I'll stop there for now, but I hope that kind of helps a bit.
My name is Hansa Bhargava, and thank you so much for the kind introduction, Parmi. And it's an honor to be here at the Emory Global Health Institute that does incredible work. As Parmi pointed out, I am a senior medical director at WebMD and a pediatrician as well. So thank you for having me here today. That was some great information from all of you. Thank you so much. And I'm going to, because
Lavery, yeah.
Yes, spoke last. I'll just jump on something that you said that was really interesting to me. And then we have a lot of questions from WebMD's audience as well, and to all of you actually, so I'll go into those. But one question I want to ask you, you talked about how authorities have lost their authority. And then we also have panic. And that's pretty obvious with everything that's going on across the world and also in the United States. How do you feel like those two are related?
Well, thank you for that. I think, it may not be as simple as loss of authority. I think that there's so much going on in terms of political discourse that explicitly undermines the authority of the institutions that we absolutely have to lean so heavily on. I think there's probably a real split between people who believe that that undermining of the authority has some traction and that they shouldn't actually, and that it affects their legitimacy. I think there's also a whole bunch of other people in society that sort of deeply believe in the authority of those institutions. So I think with that in the background, I think your question about panic has something to do with that interplay between those two groups in society. There's panic or discomfort that I think we all share because this is a serious thing. You can look at mortality compared to flu and other things and sort of get some comfort that, there's at least some sense that we may be overdoing it slightly, but it's a very serious thing. So I think some concern is very legitimate. Panic, I think, really stems from this backdrop that people are struggling with about you should panic because these institutions have no legitimacy and they're trying to take something from you or lie to you or do something untoward. So I think it's such a complex sort of mix of social anxiety, but I think that systematic attempt to undermine institutions is really what's behind all of that.
Thank you. And from that, I'll just leap into with Dr. Wu, actually. The one question that keeps coming up for us at WebMD, and I have to ask this as well, is what makes coronavirus so different from the flu? And I'll just quote a few statistics from the CDC. We have, over 29 million diagnosed with the flu. We have over 200,000 hospitalized with flu, and we have thousands of people who have died, some of who are children. I have to point that out because I'm a pediatrician. Why are we so stressed out about coronavirus when flu is rampant?
Can you hear me? Thanks for that question. I think it is a question that everyone is thinking, and a very good one. As I already mentioned, that the illness looks like the flu at first, but in the big picture issue is, I've raised the possibility maybe the mortality rate is on the very low end and maybe in line with flu. And the reality is we don't know yet. It's still too early, but let me just say one thing that I think it's important to keep in mind. Let's say it is just like the flu. if there is a pandemic and it is spread around the world, do we need another flu? Do we need 40,000 more deaths a year? I mean, if you've been to our hospitals during flu epidemic or ERs, it's tough. And we certainly care about the health of everyone in our hospitals. And the reality is, even if it is just like the flu, if it were to become common or everywhere, that would be a serious challenge.
Thank you. Dr. Sexton, I just wanted to leap on with you on that question as well. From a public health perspective, in terms of protection, and some experts have talked about buying time and doing the things that are necessary until we know more about the coronavirus. Do we have enough time if this was a virus that turns out to be, say, like SARS, where the mortality rate was 10%, or Ebola, which was almost 90%? You know, can we actually, from a public health system and public hospitals and the entire system of the United States, be capable of that?
So I think that there's a lot of work that's gone on in that area since 2014, when that question first came up with Ebola. And I think that US institutions and hospitals have significantly put time into preparedness since then. It doesn't mean that everything would go perfectly. There are going to be hiccups with these kinds of issues. And with something like this that's novel, I think that contributes to some of the fear and the panic and leads to this raising these questions of, are we prepared? With this issue of buying time, I think what we're trying to do is to see if this has passed the point where it can be contained and it's definitively going to be a pandemic, or whether we can still get on top of it. I think that remains to be seen, but I think either way, the strategies you put into place are the same. And they are this idea that you want to, as the CDC has stressed, identify the patients who may have this, isolate them so that they don't infect anyone else, including your healthcare workers. Because one of the most important things in being able to respond to a surge of cases is that your healthcare workforce isn't decimated by the illness. And then that you inform the relevant people, that you let the people in the hospital who will take care of these people know what you think is going on, and that you let public health authorities and CDC know as well, because there's a huge amount of community coordination that's necessary to try to get a handle of something like this. So I think that this is not a situation, to Dr. Wu's point, where we necessarily want to see panic. We want to see appropriate levels of concern that lead to action. And I think that with putting those kinds of measures in place, we should have some success at containing this.
All right, and I'm going to go back to, I'll just throw this out, and I'd love your opinion on this. There was, I believe, the city of San Francisco called for a state of emergency around this. And in terms of the numbers of diagnosed infections in the United States, we know they're less than 20. Is that appropriate? Is it ethical? So whoever wants to jump in on that question.
Well, I feel singled out.
I said ethical, so.
Yeah. So I tried to lay out some of the standard reasoning about under what circumstances it's ethical to apply those kinds of measures. And one of the problems that lies behind that, if you take, let's just take, for example, the notion that you should apply the least restrictive means. Right? So in the Syracuse principles and in other public health ethics principles, there's this conversation that you should first try means that are less restrictive, and then you should layer on top of that, which I think is the language CDC uses, which I really like, but you should layer on top of that other things then if you're not getting the kind of containment that you need. Well, one of the fundamental challenges that we face is that it's an extraordinarily difficult situation to collect evidence in. How do we know that we have not been successful in containing? And there's a kind of mysteriousness about whether we will ever be able in real time to get a sense about what constitutes the least restrictive means. So when you look at urbanization, like look at what's happening in China in particular, where you have these huge quarantine type activities around now cities of 13, 14, 15 million people. It's hard at one level to understand how that could possibly be the least restrictive approach. But again, I mean, who's going to object? You know, what are the processes for objecting? So I think what happens is often we just get left to decide. People, you know, countries, cities make their decisions, and then it's after the fact that we have to kind of do the unpacking and see whether or not there were different approaches. And of course, we're not as interested in history as we lead ourselves to believe, and we're not as interested in collecting that kind of evidence after the fact. So we're left in this kind of constant state of not having a good evidentiary basis for making precisely the kind of decisions that we need to ensure that civil liberties aren't violated arbitrarily.
I have a question from WebMD. Do we have, WebMD audience, I should say, do we have enough tests in the United States to handle a mass outbreak? And the test I'm talking about, is, of course, is the RT-PCR. So that was one question. And I guess JAMA, the article in JAMA about the outbreak in Wuhan pointed out that only 62% were tested. So is that a real problem, Dr. Sexton, Dr. Wu?
As already mentioned, our testing capacity is limited. I know, that is actively being addressed. So I think it is a challenge. I mean, no doubt. I mean, this is a disease that nobody even knew existed, 3-4 months ago. So I think if anything, I think we should be thankful that things can move this fast. I mean, obviously 20 years ago, it may have been a very different situation. So, but the reality is, I think that is a major challenge. We're not testing necessarily everybody who might have disease. That's the reality. I think we have to admit that. So targeted testing has been the approach so far to folks with the clear risk factors or folks who are very ill. But we hope that some of these limitations can be addressed soon.
And I think to that point that a lot of the state health departments and even individual hospitals are working on bringing up testing to rapidly scale that capacity. But I think it's important to remember too that we don't test everybody for flu. When we get to a certain prevalence in the community, we assume that somebody with the right symptom constellation has it. And we save the laboratory work, the money that's billed to the patient, all those things. And so I think that's what's happened in China, is they're working off a clinical case definition. And I think the only thing that really impacts is the mortality rate you're seeing, because they're not testing people who are barely ill enough to seek medical care. So it's impacting your denominator, and it's looking like it's more fatal than it really is. But the people who would really benefit from treatment because they're hospitalized or critically ill are getting tested. So I think that's the other important thing we'll have to consider about how we scale that capacity.
And I think that's a great point, Dr. Sexton. I think with the flu, sometimes as a pediatrician, we get asked for the flu test immediately when the patient comes in. And the truth is that a clinical case definition can often diagnose that without doing the test.
I just want to say one thing about the test too. I think it's one dimension of public health and the complexity of public health that people just take for granted. There are proposals on the table for like 19% cuts to CDC budget. And we have like RT-PCR. Well, someone won a Nobel Prize for sorting out polymerase chain reaction, and we didn't know anything about reverse transcriptase until HIV. These are kind of absolutely mind-boggling modern successes in biology. And the fact that you can have an organization that can turn around in literally 10 days, produce a test based on those technologies, distribute it around the world, is utterly mind-boggling. And it should sober every single person sitting in Congress in this country and around the world. It's mind-boggling how much we take these things for granted and how spectacular they are in terms of their contribution to what we're able to do in public health.
Great point.
I add, just to add to that point, again, back to your point about data sharing. I mean, developing these tests really fast obviously required, knowing the sequences of the virus and sharing that publicly very early on. And so that's why we're able to even come up with a test and distribute it so quickly.
And on that data sharing, I'll just hop on another question. It was actually going to be directed to Paul for a second, but I want to direct it to the health systems as well. I mean, data sharing obviously has its benefits in having open source platforms, but and this is for both the airports and the health systems, the people at the front lines, how do they get the real-time information? I mean, in the hospitals, we have health record systems like Epic and HealthStream. We've got content on media like Medscape, WebMD. We have Alamino Health. Well, how do people at the front lines actually get that information? Because the information is changing by the minute. We know that.
Exactly, and we try and get this information out in as close to real time as we can. For example, today at 2 o'clock, we have a conference call with the other, it's either 7 or 11 other funneling airports in the US through our trade organization called Airports Council International. So we start to trade information, what's working well at other places, what isn't, what are you doing with your employees, how are you communicating it. But what we learn from the CDC and from others, such as other airports, is we try and get it out to the employees, to their companies. We try and get it out to Delta and United and the food and beverage folks, the people at Starbucks. You know, there's 60,000 people at the Atlanta airport that have a badge. Unfortunately, they're not all there at the same time, but that's how many employees are at their airport. And how do we get them that information? Because if we don't, then they're going to start getting it from places that may not be the best, and suddenly they don't come to work because they're worried. So we try and get that out through conference calls, through the usual emails. That's the quickest way. Here's the latest guidance, but we try and get the information out as quick as we can.
Dr. Sexton.
And I think along those lines, one of the things to remember with data sharing and the availability of some of this information is that it is all out there without a lot of filtering or context or explanation. And that has downsides in addition to the things that are good. For example, that Johns Hopkins graphic of what's happening with cases, there was a couple-day period 2 weeks ago where it was just going like this. And so if the average person had opened that on their computer, they might have thought this is completely out of control. When what that really reflected was differences in case counting, catch-up testing, changes in the case definition, but that context isn't provided. That's just unfiltered data that's there. And by the same token, if we started telling our employees, hey, we fielded 3 phone calls today about concern for coronavirus, people might get the impression that there are people wandering around in Emory Healthcare who are at risk, when we were actually fielding calls for, hey, I ate at a Chinese restaurant and now I have a cold, should I be worried? And so it's that kind of information that has to be put in context for people in a way that makes sense and that is both accurate and reassuring. So you want people to have the real information. If we had a patient, we would want people who work in the hospital to know that, but we need to protect patient privacy, and we need to make sure people have the facts and that they get the information that they can act on.
And from that, because of all the information that you're talking about, I'm going to turn to a WebMD person's question, which is this, and this is really interesting. The question is, should we prepare for this like we would prepare for a major storm, like getting batteries and water and food, and should we be wearing masks? Who would like to jump in? Go ahead.
So I can field the mask question because that has come up a lot.
Sure.
And there is absolutely no indication in the United States to walk around in a mask right now. Please don't. What that does is it uses masks that we need in the healthcare system for people who are trained in how to use them and who legitimately need them to protect themselves. For one thing, when you're walking around outside, you've got airflow. You're not having close, prolonged face-to-face contact with somebody. You don't need a mask on. It's also, there's never been good data on whether wearing surgical masks really protects people against something like this in the community. All of that data is in healthcare settings where you got personnel who are trained in how to use them, following other infection control measures like washing their hands and not touching their face, and who have other engineering controls like airflow in the rooms that protects them. So the people who should be wearing a mask are anybody who actually is ill, who is seeking medical care, should put a mask on in a waiting room in a healthcare setting so that they don't transmit to the healthcare workers or the other patients. But other than that, there's no indication to wear a mask.
Thank you for that answer. Dr. Wu, did you have anything to add to that?
Oh, I think, preparing for emergencies, to me, that's a no-brainer. That advice is out there already for hurricanes and everything. So, there are some things that are never a bad idea, and this is just another reason. So, I think that was a lot of the messaging this week from CDC is that the public should just be aware and prepared. Again, not panic, but just be prepared.
Great. So we have a few minutes remaining.
Could I just add one other thing to
absolutely.
that? I always had this notion that one of the things that happens when you acquire wealth as an individual or in society is that you kind of feel you can purchase protection. You can purchase kind of anything. You can buy a safer car, you can live in a safer neighborhood, you can buy those things. And I think that this balance between prepare for emergency by stockpiling canned goods in your basement and having a more sensible conversation about our sort of human vulnerabilities in the face of these issues. I think those are potentially very constructive conversations to have. Hey, what could happen? How can we get our minds around the fact that we can't simply purchase our way out of every one of these threats, that we may as humans just de facto be vulnerable to some of these things as well. I don't think we go there very well, but I think those could be very productive conversations.
Parmi, did you want the audience to ask questions, or are we done? Okay. Okay.
Let's give everyone a round of applause. Thank you.